We're going to start into the upper extremity now, starting in chapter 4, the shoulder complex. And as we normally do, we are going to start with the osteology of the shoulder complex. So the learning objectives for this section are to be able to identify the bony landmarks of each joint and their anatomical position to one another. As you found in lab, some of the bony landmarks are palpable, some of them are not. Many of the bony landmarks in the shoulder complex are palpable, and we will palpate all of them. So we're going to start with the sternum. So who knew the shoulder started at the sternum, right? Well, now you do. You know that. So the interesting thing about the shoulder is the sternoclavicular joint is the only bony attachment of the upper extremity to the trunk. Digest that for a minute. Lots of muscular and ligamentous and connective tissue attachments, but the only bony attachment is the sternoclavicular joint. So it starts with the sternum, which articulates with the clavicle, which articulates with the acromion process of the scapula, and the glenoid fossa of the scapula articulates with the proximal humerus. So the entire upper extremity is attached right there at the sternoclavicular joint. Crazy, right? So I always think of this as medieval knights when they were fighting. The devastating move was to get your opponent's clavicle on their sword arm, thus disabling the sword arm. Okay, so think like a medieval knight, and that's the only bony attachment to the trunk for the upper extremity. Pretty interesting, right? So the sternum, if you've taken CPR before, which I think many of us have, and you will know that the body of the sternum is where you apply the pressure for CPR. The manubrium is the most superior shield-shaped portion of the sternum that articulates with the clavicle, and that makes up the sternoclavicular joint. The body is the middle portion, and it's the anterior attachment point for ribs 2 through 7. And the xiphoid process is the inferior tip of the sternum, and xiphoid means sword-shaped in Latin, of course. The xiphoid process is what you want to not press on when you're doing CPR. You don't want to poke people with their own xiphoid process. So the sternum is part of the axial skeleton. So that's the axial attachment for the upper extremity. The clavicle is the next bone in the chain. So I don't have a clavicle with me. I don't have a sternum with me, well, except my own, but I don't have a bony model today, but I do have the rest of the bones down the chain. The clavicle is the S-shaped bone linking the scapula to the sternum. So the acromial end is the flattened lateral end that articulates with the acromion process of the scapula. And the acromion process of the scapula is what we typically think of as our shoulder in the vernacular. The acromioclavicular joint is formed by that attachment. The medial or sternal end of the clavicle articulates with the manubrium of the sternum, forming the sternoclavicular joint. And the sternoclavicular joint is a very interesting joint. It's a saddle joint, just like the joint in your thumb, our first metacarpal joint, that provides a lot of movement in the thumb. The sternoclavicular joint is also a saddle joint, and it provides interesting movement in the upper extremity. The scapula, I think scapula is a lovely bone. It's a favorite of mine and often manipulated in physical therapy. So it's highly mobile, it's triangular shaped, it rests on the posterior side of the thorax. So there is a functional joint between the anterior side of the scapula and the posterior thorax. We call it the scapulothoracic joint, and we'll talk more about that. The subscapular fossa is the slightly concave anterior aspect of the scapula, which allows the scapula to glide smoothly along the convex posterior rib cage. So the subscapular fossa is the concave portion of the joint. The rib cage is the convex portion of the joint, and it does all sorts of great movements, which we will talk a lot about. The glenoid fossa is the slightly concave oval-shaped surface. It's on the lateral side of the scapula. So if I hand you a scapula and say, hey, is this a left or a right? You're going to find your glenoid fossa. You're going to orient it laterally. And doing that, I'm going to know that this scapula is a left scapula. You can tell the anterior portion because the subscapular fossa is on the anterior. You can tell the posterior because the scapular spine is on the posterior. And that orients us to right and left. So the right and left scapulae are mirror images of one another. The subscapular fossa cannot be palpated, even though you can palpate just the lateral edge of the subscapularis going through the axilla. The glenoid fossa cannot be palpated on a human being. The glenoid fossa is the cup part or the socket part of the ball and socket joint. So it accepts the head of the humerus, forming the glenohumeral joint. As you can tell, it is much shallower than the acetabulum of the hip. And so even though it's a ball and socket joint, just like the hip is, it is not as stable as the hip. However, it is way more mobile. So stability and mobility are two ends of the spectrum. And while the shoulder is not as stable as the hip, it's a lot more mobile. These superior and inferior glenoid tubercles border the superior and inferior aspects of the glenoid fossa. And a tubercle is a little bump. And so a little bump is usually a muscle attachment. And that's what these guys are. They serve as proximal attachments for the long head of the bicep and the long head of the tricep. So bicep superior and tricep inferior. They also cannot be palpated because they're inside the joint capsule. The scapular spine, however, is easily palpable. It divides the scapula's posterior aspect into the supraspinatus fossa and the infraspinatus fossa. And the supraspinatus fossa is where the supraspinatus muscle belly is, and the infraspinatus fossa is where the infraspinatus muscle belly is. So on the diagram on this slide, that's also from the book, it shows the muscles in place. So those are all palpable on an intact human being. So we will be palpating them in lab. The acromion process is the wide flattened projection of bone that is the most superior lateral aspect of the scapula. It's where you carry your purse or your backpack. It's that little hook on the end of your shoulder. It forms a functional roof over the humeral head, and it protects delicate structures running through there, such as nerves, tendons, etc. So if you look, there's not a lot of room in there. It's pretty narrow. So if anything gets inflamed or there's an internal derangement, impingement is very possible in the shoulder. So we'll be talking a lot about shoulder impingement and impingement syndrome. The coracoid process is on the anterior aspect of the scapula. It's the finger-like projection from the anterior scapular surface. It's the attachment site for several muscles and ligaments of the shoulder complex. It is very palpable on a human being. If I think of it as if you draw a line from your sternoclavicular joint over to your acromion process, the coracoid process is going to fall slightly inferior to that line. And we'll practice finding it in lab. The medial and lateral borders of the scapula meet at the inferior angle of the scapula. Another name for the medial border is the vertebral border because the medial border is closer to the vertebrae. Another name for the lateral border is the axillary border because it's close to the axilla or the armpit. So those are both palpable. There are also handles for holding on to the scapula when you're mobilizing it. Always an important thing. The inferior angle is also palpable, and it's a handle for holding on to the scapula when you're palpating. Just like with the os coxa, there are lots of muscle attachments all along the edge of the scapula. So these flat bones, they are big, broad areas for muscle attachment. They are also, the interior of flat bones is where red blood cells are created. Kind of neat. The superior angle of the scapula is surprise, surprise, on the superior border of the scapula, and it's just superior to the supraspinatus fossa. So the proximal humerus articulates with the glenoid fossa. It's the attachment point for many ligaments and muscles linking the upper extremity to the shoulder girdle. So when we talked about muscles in the lower extremity, a lot of them work together. Of course, no muscle really works in isolation in the real world, even though we talk about their individual motions. Nowhere is this more true than in the shoulder. The shoulder muscles work together in lots of different ways to cooperate to perform the movements and the control that we need. Our upper extremities are the way that we are interacting with the world. We need to control them in a lot of different ways. And the complex muscle attachments and muscle interactions really help us with that control. So it's very interesting. If you have any one of the joints in the shoulder or the muscles in the shoulder that is dysfunctional, it's going to cause problems all the way down the kinetic chain. So it's something to think about. The humeral head, it's nearly a half of a full sphere that articulates with the glenoid fossa. And so there's a lot of room for movement in that joint. The humeral head is not palpable, so because it's inside the joint, kind of makes sense. However, the lesser tubercle, which is a sharp anterior projection of bone just below the humeral head, that is palpable. The greater tubercle is the larger, more rounded lateral projection of the bone, also very palpable, right here on the lateral aspect of your shoulder. So if you recall palpating the greater trochanter, and we would internally and externally rotate the thigh to get that trochanter to move so we could feel it, you can do the same thing with the greater and lesser tubercle. Internally and externally rotate your shoulder, and you can feel those tubercles bumping around underneath your fingers. The intertubercular groove is also known as the bicipital groove. It divides the greater and lesser tubercles, and it's called the bicipital groove because it houses the tendon of the long head of the biceps. So very palpable, that as well. So when we're palpating these structures in lab, depending on the muscle bulk that each individual person has, it might be easier or more difficult to find those structures, but they should all be palpable on a person. And the point of knowing that is so you can find landmarks on your patients and you can treat whatever injuries we're dealing with. A lot of times when I'm doing manual therapy, say I'm working with someone with a frozen shoulder, I might move them in a particular way and they say, wow, that hurts. And I ask them to localize where it hurts. And what I'm trying to do is I'm trying to figure out what structures are tight or weak or compromised in some way to know what's going on with them. So if I know where those structures are supposed to be and I know how to find them by palpating, it's a lot easier for me to treat that patient. So the deltoid tuberosity is on the lateral aspect of the upper third of the shaft of the humerus. It's the distal insertion of all three heads of the deltoid muscle. So it gets a lot of pulling on it. It is palpable on a person, but people that have really muscularly developed triceps, it's a little harder to find. The radial or spiral groove runs obliquely across the posterior surface of the humerus, and it houses the radial nerve. The radial nerve innervates a lot of the posterior muscles on our upper extremity. And the spiral groove also helps define the distal attachment for the lateral and medial head of the triceps. So the lateral head of the attachment of the lateral head of the tricep is lateral to the radial nerve, and the medial head is medial to the radial nerve. So it kind of gives us our definition of those locations.